We're back with our second episode in our new series with Academy Health on the stuff that drives us nuts about healthcare in the United States. In episode 1, we talked about how American healthcare is expensive by design because it's a patchwork system with a lot of interacting layers. One of those layers is policy, like the One Big Beautiful Bill. This particular policy was focused on cutting costs and waste, but is it actually just going to make healthcare more expensive? Have you seen any evidence of higher healthcare prices in your life so far this year? That's the topic of this week's Healthcare Triage. The One Big Beautiful Bill, also known as H.R. 1, made some major changes to Medicaid in the United States. At face value, the bill's goals sound reasonable enough: reduce costs and increase accountability in public programs. Unfortunately, it's a lot more complicated in practice and will likely make healthcare more expensive, which is the opposite of what the system needs. Annoying, right? And that's why we're combining the powers of my organization, Academy Health, with the powers of this channel to create a series that addresses the kind of stuff in healthcare that we're sick of dealing with. I don't want to pay more money for healthcare. Do you want to pay more money? Stan, do you? Does anyone want to pay? No one wants this. So how does a bill aiming to cut costs actually increase costs? Let's break it down. Medicaid is the primary source of health coverage for millions of low-income Americans, and the One Big Beautiful Bill has introduced some of the biggest changes to the program in decades. Chief among them are new eligibility conditions, like work requirements for many enrolled adults. Under the new law, adults between the ages of 19 and 64 who are not exempt must show that they are working or participating in qualifying activities for at least 80 hours per month in order to maintain coverage. States must verify this information during enrollment and at periodic eligibility reviews. That sounds simple enough, but building the systems needed to enforce the policy is extremely expensive, which starts to defeat the purpose. Who keeps track of and verifies these working hours, both at enrollment and during periodic reviews? States do. And in order to do that, they have to create whole new administrative systems to verify employment, track work hours, determine who is exempt, and handle exemptions. On top of that, the bill also requires states to reassess eligibility every 6 months in many cases, adding an entire extra layer of work to the system. For example, states will have to build complex databases that connect wage records, tax data, and eligibility files so that they can make sure people are complying with work rules. They also have to hire more people to process reports, respond to questions, and review cases. In Kentucky, one estimate put the cost of all that at more than $270 million. Those are just the startup costs. Running the system year after year requires even more money for stuff like maintenance and wages for extra staff. In Georgia, administrative costs related to work requirements cost twice as much as the actual health care being provided to patients over the same period. In Pennsylvania, increasing staff to manage work requirements has been estimated to cost $600 million. This creates huge challenges for state Medicaid systems, many of which are already stretched thin. Adding new reporting requirements and more review requirements could just overwhelm them even more. Supporters of the bill argue that the requirements will reduce government spending by shrinking the number of people on Medicaid. But those savings come from people losing health insurance. Can't we just make healthcare more affordable? To be fair, the bill acknowledges that states will have to shell out a lot of money for these new administrative costs, and it includes a one-time payout of $200 million to help cover some of it. But that payout is split across all the states, leaving most of them with less than $2 million each, which is to say a fraction of what implementation alone will cost, to say nothing of the ongoing expenses. One analysis estimated that county agencies would need to manage eligibility for hundreds of thousands of beneficiaries, resulting in $370 million in administrative expenses over 5 years. And don't forget another important cost that rarely makes headlines: due process. When the government denies, reduces, or terminates a public benefit like Medicaid, people have a legal right to appeal the decision. If someone believes they were incorrectly removed from coverage, they can request a hearing and require the government to justify its decision. In a system where millions of people may lose coverage, appeals and legal challenges are inevitable. So states have to maintain things like legal staff, documentation systems, and case records to ensure that every coverage decision meets the appropriate requirements. These protections are important, but they also are costly to administer. According to health services researchers, these administrative and legal obligations could cost hundreds of millions of dollars, resources that could be spent delivering and improving actual health care. So the effort to cut Medicaid spending might just generate new government spending in a different place, which raises an important question. If the government is spending hundreds of millions of dollars just to remove people from the program, is that really saving money in the healthcare system? And that isn't the only important question. Health services researchers are also asking how many people might lose coverage due to administrative barriers rather than changes in income or employment, and what the downstream consequences are for everyone involved. We already know that work reporting requirements create significant administrative burdens while doing little to increase employment. Many people lose coverage simply because of processing errors or because they can't navigate complicated reporting systems. These data are important. If your big, beautiful bill's real-world effects are higher costs and less access, that seems kind of ugly. That tension is exactly the kind of issue health services researchers aim to understand. By examining administrative data, tracking state budgets, and evaluating policy outcomes, they help reveal the true cost of health policy decisions. When it comes to healthcare policy, the biggest expenses are not always the most obvious. There's the bottom line of the federal Medicaid budget and the number that the one big beautiful bill aims to slash from that. Then there are the expenses that appear later in call centers, eligibility offices, court hearings, and administrative systems that must process millions of decisions about who receives care and who does not. Understanding these costs is essential for designing policies that actually improve the healthcare system, which should be the overarching goal. And it's exactly the work that health services researchers are doing. Unfortunately, their job is made harder by how politicized healthcare has become in America. Next time, we're looking at how partisan messaging about healthcare creates a false binary and why we need policymakers to focus less on politics and more on people's lives. Academy Health is all about making research matter, turning evidence into real-world impact on health and healthcare. That's exactly what Healthcare Triage is about too, breaking down the complex, sometimes messy health policy and research stories that affect all of us. Basically, we're tired of the nonsense, and that's why we've teamed up to bring you this important series. Let's fight the nonsense together. We'd appreciate it if you'd like and subscribe to the channel down below. Consider going to patreon.com/healthcaretriage, where you can help support the show, make it bigger and better. We'd like to especially thank our research associates, Joshua Crow, Edward Liljeholm, and Christopher Learn, and of course, our Surgeon Admiral, Sam.